Thank you so much for joining us today. My name is Rebecca Kiesling, and I am Managing Director at the Benjamin Rush Institute. I am excited for today, part of our virtual event series, which we started in response to the COVID-19 pandemic. We've had nearly 20 of these now, and we're going to continue them, hosting them about once a month, talking to a variety of different experts across free enterprise healthcare, which is our mission. We've been around trying to educate medical students across the country and internationally about free market, free enterprise alternatives in healthcare that they're just not receiving in medical school. We have the great opportunity to speak to so many different experts, whether they're physicians, policy experts, and other people doing just really wonderful things in this arena that medical students just typically are not available and I don't have the opportunity to speak with. I had the great opportunity to meet this person, this physician that I'm speaking to today and that we're introducing you all today. When I spoke at a conference about 6 months ago in Texas, speaking about surprise billing. And so important for our physicians and our medical students to understand the billing aspect of what they're into. And I got the chance to speak to beforehand and then during Dr. Paula Muto. And to say I was impressed is to be very understated in how and what I felt. She's amazing. And if you look on one of her websites, it really sums up why I was so impressed and why we're very excited to introduce her to you today. This is a quote off of the UBERDOCS website. It says, "I am a surgeon. Like my father before me, my brother, my 2 uncles, I am even married to one. You could say it's the family business. That's why I take it personally when patients can't get the care they need because it's too difficult to navigate the system. I also take it personally when I see my colleagues struggle to remain in practice without compromising their independence. Rather than complain, I decided to fix it. With the help of a team of doctors, nurses, healthcare professionals, and experts in insurance and information technology, we developed a simple web app that connects patients to specialists for a transparent price using a health savings account or credit card. So we do the unthinkable, increase the access while decreasing the cost." If that's not what kind of the Shangri-La of healthcare is in a nutshell, I don't know what it is. Advocacy, taking healthcare and what healthcare should be into your own hands. That's what Dr. Paula Muto has done. She is the UBERDOC founder and CEO. She's a practicing vascular and general surgeon in solo practice and the owner of the Muto Vein Center. She is a member of a family of physicians and surgeons who have collectively practiced medicine in Massachusetts for over 50 years. She's an outspoken advocate for patient care and is so passionate about women's health issues as well. She is a person that other physicians look up to, medical students can look up to. She is a mentor. She is a wonderful person. I can't wait to introduce you all to her if you haven't heard from her already. She's going to speak on UBERDOCS, but also what advocating for your profession can be like and why she is so passionate about working with medical students like we are and what all of this can do for healthcare in general. So I am going to introduce you all to Dr. Paula Muto. If you have questions, please ask them here on Zoom. For the medical students that are in their own who are in your events right now, you can text me your questions and we will get to them. I see Dr. Diana Granita on board and she's saying we should clone her. I absolutely agree. So I am going to introduce you to Dr. Paula Muto right now.
Wow. Well, that was quite an introduction. So I think I'll end right here before I start because I don't think I can live up to that. But thank you, Rebecca. That's lovely. And welcome everyone. I'm thrilled to be here. I did meet Rebecca. It's weird to think it's 6 months ago. And we absolutely hit it off. And I love talking to medical students. I love to kind of like get everybody excited and passionate about how we can change the system and how we can change the system together. So today, Rebecca's already kind of introduced who I am. I'm a surgeon and in practice, and also a disruptor in the healthcare space with a digital healthcare company. And I kind of wanted to talk today a little bit about what's the story of healthcare and what we can do and what we kind of need to do to change it. And there are many, many opportunities right now that are super exciting, especially for young people to understand. And the more you understand of how the system works, the better it can be to change it. So I think I'm going to share my screen now, Rebecca. Is that right? Okay. I don't know if I'm seeing welcome to BRI.
Yep, you should be able to go to whatever you want on your.
You are screen sharing. Okay, I got you. All right, hold on. Okay, let me hear. And let's see, I have to start my slideshow from the beginning. Okay, there we go. All right, can you see that now? That's all good, right?
You're good.
So we're going to start with the question, why not, right? Everyone tells you why we can't do something because that's the way the system is. It's like, but the real issue is why not? So I'm going to start with my favorite story. When I was a little girl, Little Engine That Could was my absolute favorite story. It still is, about the circus train that can't get over the mountaintop, and all these big steam engines go right by it saying, forget it, we're not stopping for you. And then the little engine, who's by the way a girl, that's actually a girl engine, stops and says, we're going to help you. And I was like, you can't do that. And it's like, yes, you can. And so that's kind of how I want to start the story. It's like, here we are, all these, think of us as the doctors and patients in this little wagon, because we really are being left behind as the steam engines go by us. But how can we, in fact, take our healthcare, take our patients over that mountain and make a change? So how does the story begin? Its story begins for all of you, all of us. We all started in the same place. When you become a physician, you decide very early in life to do that. You make sacrifices that are both personal and economic. Early on, you decide that you're in that library instead of out playing or partying or doing whatever. It takes years to even begin to prepare yourself for medical school, let alone getting into medical school and completing medical school, and all those years of training and deferred compensation. You see many of your friends, maybe even spouses, family members who are now graduated, they're moving up the ladder in their corporate world, and you're still sort of in this hierarchy working through in this apprenticeship. But the one thing that medicine has is we have tremendous amount of influence from our peers and mentors. And this is where the story really is important, because right now, as Rebecca kind of set this up, your peers and mentors are the people that are around you all the time. And sometimes, and I think Nelson Mandela said it best, sometimes when you're in the middle of something, you can't always see either in his words, it was the corruption, but you can't always see the problem. When you're in the middle of it, it's all you know. So it's very important, especially in medicine, because one thing that we all have in common, no matter where we practice, is we all have a bond about how to take care of a patient. And that kind of transcends a lot of the areas that we work in. So especially for a student to find peers and mentors outside of everything around you, to begin to question and to be asked the questions. And I think that's really important, because as we are looking at our current medical system, is that there's a very deep-seated dissatisfaction. That dissatisfaction isn't when we started to study to go to become a doctor. It certainly wasn't when you were applying to medical school. It's certainly not when you're in medical school. Where does this chronic dissatisfaction come in? But we're seeing it in younger doctors. And this is where this is my particular challenge, because I think part of this is why we need to fix this system is for the young people, because this dissatisfaction is pretty large. So 56% of physicians currently report burnout. that means every other doctor. So if you're in a hospital rotating through as a third-year student, or perhaps you're in a practice rotation, or if as a resident, that means 1 out of every 2 doctors is not happy. That's not very inspiring. And of course, they point to the excess bureaucracy. The lack of respect. There seems to be kind of a sense of we don't all belong together, or we're not associating together. Increased computerization, we don't have to go into that. Electronic records has been the bane of everyone's existence, the thorn in our side. We spend a lot of time documenting the invoice instead of taking care of the patient. And of course, insufficient compensation, and that isn't a monetary value per se. What it is it's just not, it doesn't seem like that the investment that you make to become a doctor is getting paid at the end. So that compensation isn't necessarily monetary. It's also satisfaction. And of course, a lot of this is rooted in a lack of clinical autonomy. We didn't go to medical school because we enjoyed that we weren't people who were, that weren't driven. To become a doctor, you are absolutely driven. You are absolutely the one who's going to be the top of the class, going to be the one who shows up early, going to be the one that is late. It's hardly anything that has, most of it is all driven by autonomy. So this past year has been, and I won't say year, it's really now years, I should say past years have been a challenge. And if you ever watch the great musical Hamilton, there's a great scene in it, the world turned upside down, where everything goes into slow motion, right? And you have to stop and pause. And I really felt like the pandemic was like that, especially for healthcare. We had to stop and ask ourselves, boy, can I see my patients in the office? Do I have to do something else for them? How do I manage this chronic disease? Did I really need to order an EKG on a patient every 6 months? Was it going to change their outcome? A lot of things made us question. And of course, it put significant strain on our existing resources, which were already challenged in many ways. And I think in some ways, COVID really kind of pulled the curtain back on a lot of things that were going on. We now have tremendous uncertainty still within the hospitals, as well as in a lot of the residency programs. Even there's just a lot of instability, a shortage of staff at all levels. We have people who aren't answering phones to make appointments, and we have people who can't staff an ICU at night. We have issues of OR technologists, nurses, as well as available physicians. We've had to take a very rapid adoption of digital health. I mean, more than any other technology, there was no introduction. All of a sudden, all of us are now online with Zoom talking to a patient. And we had to make those adjustments. We also made a significant shift toward outpatient services, because what patients didn't want to go to the hospital anymore. I don't want to go to the hospital. I'm going to get COVID if I go to the hospital. So all of a sudden, we've really made some significant shifts in the way we connect with patients. And all of this has led to a significant pent-up demand. We already know that there's data out there of stage 4 breast cancers. I literally just operated on a woman who was in the hospital with COVID and in a rehab and had problems and hurt her hip. And she came to me at the end of all of this with a giant 2.5 centimeter lump in her breast that she said, oh, it hurts here, I have pain. Now, why no one discovered it during all of that, we won't go into, but the point is that she put off her mammogram for about 2.5 years because of COVID and not able to get in, and also just not being afraid to go to the hospital to get that mammogram. She's going to be fine. So during this time period, leading up to COVID and then accelerated after COVID, we've seen a significant shift in the way doctors practice. A lot of doctors are employed, they're by hospitals. Now, it's 70% are employed. I will say that a significant number of practices are still independent. There's about 30, it's not just 30% are independent, because a lot of physicians that are employed by hospitals are people that are that are like anesthesia or emergency medicine, things that are only hospital based. But there are also physicians who could be practicing outside of a hospital setting, who are now employed by hospitals or corporations, which are taking a big chunk of a lot of these practices now, private equity and private companies. So hospitals own just about a quarter of US physician practices. So that means to me, I'm the glass half full person, that 75% of practices are still independent. And those are those people who are in the rest of the country, who are outside of the metropolitan areas, who are actually in taking care of patients, the local doctor, the local community surgeon. These are people that are actually doing the care. So 75% of practices are still those people. So we can't always kind of throw away, assume that everybody is employed. But it is a trend that we have to pay attention to. Why are doctors not being able to remain independent? Why are they moving into selling their practice either to the hospital or to a private equity? I mean, these are questions that we need to ask because this trend is a little bit disturbing. When you hit that halfway point and you go into the majority, you really have to wonder, who is your doctor working for? Is it you? Is it the patient? Or is it something else? So much of this has brought up a lot of distrust, a lot of uncertainty, a lot of anger, like who's in charge? Like, where do we go as doctors? Oh, we go to our national organizations or our societies. But they're not necessarily representing our interests anymore because they tend to be in alignment with whatever the policies are, whether it's the hospital association or these networks or oftentimes insurance companies. There's a lot of industry people that are in these chief medical officer positions. There's hospital CMOs that don't actually work on the doctor side. They work on the administrator side. And so oftentimes doctors feel that they have no one who's really representing them. And of course, we want to blame. It's the blame game. Oh, we're going to blame government regulations, insurance requirements, employer control. I mean, there's so much to blame, but the point is, the result is that we have this wall, and the wall that was created because of all this distrust is really between the doctor and the patient, because we have given up a little bit about how we are allowed to interact with that patient in the process of all of this distraction. And this is where I think is the core issue, where the dissatisfaction now isn't just on the doctor side, it's on the patient side. So we talk about physicians moving from a fee-for-service model to a commodity. Now, fee-for-service means you deliver someone's baby, they give you a goat. That is about the purest relationship. And I can guarantee that most of the medical students would be like, yeah, that's exactly how I envisioned medicine, just like that. But now we're kind of like a commodity. Like, you can buy doctors, you can buy mid-level physicians, you can buy prescribers. They even call us providers. And I always quote this article, which if you haven't seen it, you have to see it. We are going to cancel the term provider when it's referred to a physician, because it was used in Nazi Germany to associate with German physicians. They wanted to devalue, Jewish physicians. And so they called them providers. And then when it came into the insurance world, it was used for like women and minorities entering medicine. The word provider was added. So we don't want to use the word provider when we talk about a physician, because that really is an anti-Semitic assumption. So I just kind of put it plug in, but it's a wonderful paper to read about all of the doctors during the Holocaust who survived it and came here and became great leaders in their fields. But basically, we have to kind of think about this movement. We look at emergency medicine and anesthesia. They've been really struggling a lot with, because they've been purchased by these large corporate organizations. And then there's a lot of direct-to-consumer platforms out there offering grossly discounted services. I believe Teladoc is like gives a doctor $20. Like $20, I'm going to be at my Dunkin' Donut having fun making coffee, because honestly, those kind of models are really quite a devaluation of the doctor. So this is kind of what's out there. Again, they say fee for service is a dirty word, but what is it? What's the opposite of fee for service? We're a commodity. And so those are kind of the things that has been pushing us in this direction. So healthcare in America is really not really very fair. And I think everyone agrees. The politicians agree, business people agree, employers agree. Pretty much everybody agrees that healthcare isn't really what it seems. Everybody's got their hands in everyone else's pocket. And you wonder who is on your side. And I know a lot of employers feel this way because when they're negotiating, you have all of these players, these big insurance companies, and you have them sort of interacting with hospitals. So I actually went to draw this out, because it was so confusing to me in the last few years trying to understand how to navigate healthcare. I'm trying to disrupt it and change it. And I want to know, why is it so complicated, and why, and what are these relationships? So at the very beginning, at the very onset, what you really have is you have a patient who goes to a doctor and can pay the doctor. That's that you deliver a baby, you get a goat or a bag of grain. That's the accountability. Now, patients also are taxpayers, and they can pay the government, and the government will then pay the doctor, either through Medicare, Medicaid, the Affordable Care Act. That's all subsidized plan. But most patients in this country, a third of the time the government is paying, but about 2/3 of the time you're having employer-based insurance, which means now the patient is working for an employer who decides what their healthcare can be. But it's not that the employer is paying for their healthcare. The employee is actually working for their healthcare. It's called a benefit, and benefits arose in the 1950s. Actually, right after World War II, Truman put in a wage freeze to prevent employers, especially in the Midwest factories, from stealing, talent from other factories. And they needed to, for the war effort, they needed to stay in those factories. So that he put a wage freeze in. And because they couldn't give you more money, they created benefits. And so the employer started to offer insurance, health insurance benefits. And then come into the 60s, if you were too old to work, or if you were too poor, you didn't have a job, the government stepped in and you created Medicare and Medicaid. And Harry Truman and Bess Truman were the first two patients enrolled in Medicare. So it came from that, it came from wartime, that the employer would in fact pay for your health care. And then after that, it just became a given that you were going to get your health care through a benefit where you worked. But the employers also deal with the insurers. And that's a two-way street. And there's a lot of back and forth that goes on. There are also these direct-to-consumer health plans that are somehow also kind of managed by insurers. Patients can buy these plans, and then ultimately some of the money filters to the insurer. The hospitals and the networks go back and forth with the insurers all the time, setting a price, and that's part of the surprise bill legislation and the price transparency law that said, hey, you got to set your price. And the hospitals don't want to tell their prices because each insurer has a different price and they don't want to play their hand, right? They don't want to show their cards to say that they're giving this insurer like one rate, another one, another. And then, of course, there's the PBMs and the GPOs, which are the pharmacy benefit managers. These are the people who determine the drug price. It isn't the pharmaceuticals who determine it. It's in fact these middlemen who are in fact backed by insurers. So this is not patient-centric care. This is completely the insurer is kind of the black hole where everything, it's like a magnet where all of the revenue and it always goes back to the center in the insurer. The most disturbing part of all of this equation, of course, is that the doctors are on the periphery of this, but the patient isn't even on the patient is way up here in this corner. Patient is not in the middle of this equation and has very little control of this. And unfortunately, all these yellow lines are negotiated with private equity. So there's another 10 or 12% of the healthcare dollar that gets siphoned off in every one of these relationships. So I put this up here because it took me a while to figure out, and it's a confusing slide, but just trust me to say that, when you follow the money, you follow the pennies in healthcare, it all seems to end in the same place. See my next slide. I'm trying to just switch there you go. So when the insurer has so much power in the equation, what does that mean? Well, the Affordable Care Act was about taking Medicaid patients and moving them to an insurance product, right? They were typically patients that we would have taken care of through a Medicaid product, and you said, no, we're going to move them into these insurance subsidized plans, the working poor, which was really moving them into a managed care environment. Now, what managed care means is we have to ask permission. Before I would send a patient to the hospital to get a CAT scan because I was concerned about some abdominal discomfort. Now I have to stop, make a phone call, put in a request, put in a referral, wait for somebody to approve it. Okay, that's called managed care. That's what so someone's managing the care of the patient. And so with all of this, the administrative costs have gone way over. I have been on the phone with now not one, but two, but three layers of reviewers, all getting paid probably $50 to $100 an hour to review something that costs $250 that the insurance doesn't want to pay. So it's kind of gotten a little out of control. The ACO models, the accountable care organizations, have really failed to improve cost control. They were invented to try to create patient-centered care, but I think from the previous slide, it's really hard to create a system of patient-centered care when there's no infrastructure that exists for it. So I'm concerned because I work in an inner city with a very underserved population with a federally funded health center and family practice residents that I've been on faculty. My husband and I have been teaching for years. And I've seen in the last decade how the disparities are happening, where these poor people who have been victims of managed care early on are now being, their course of their treatment is being delayed significantly. And these disparities we know now. We know there's tremendous amount of disparities, and we call it access to care, but they can find me in my office. I can't order what they need. So the issue is really access. It's the insurance companies and with managed care are blocking access to life-saving procedures and life-saving imaging, and because of this model. Data acquisition is massive. Everybody wants to collect data. Every piece of data we collect is a little bit wrong because if you want to get to the next screen, you're just going to say no one smokes. As soon as you say someone smokes, it opens 3 or more screens. Guess what? No one smokes anymore. You just need to get through the electronic record. And that the safety of that data is in high question. Who is it being shared with is a real issue as well. And now we've gotten to the point where the deductibles are like higher than the utilization. People are paying really a high cost in deductibles that may be beyond what their actual utilization is. And of course we have this consolidation of verticals. What do we mean by that? The insurance companies from the prior slide, they're controlling the prescriber, the insurance, and they also own the prescription, the way we get our prescriptions. And all that data is universally shared. So when you go to the electronic record to order a prescription, you have to go through 3 different passcodes to get into your electronic record. But the moment you e-prescribe, the back door is an API wide open to CVS, Walgreens, or wherever. So we control data on the front end, but not the back end. So this constant kind of like sharing the sieve of data is really leading to a lot of confusion and a lot of violation of a lot of principles of privacy that hasn't even begun to be addressed. So I always say, pay no attention to that man behind the curtain, because really that's what insurance is all about, right? That's what our system is all about. It's not just insurance. There's no transparency. We have no idea. Like, oh, just push a button and you're going to get a prescription. We don't know what the price of that prescription is. It could be, as one pharmacist said, it's like the price of oil. It goes up and down every day. It's like, not really. It's a pharmaceutical. It's a pill. It comes off the assembly line. It has a price. But now we play with those prices. There's no accountability. I won't even say less accountability. There's no accountability because who are you blaming? Where can you retrace your steps? And of course, the denials are massive. And again, I stress this because I work in a poor community. The denials hurt the poor more because the poor can't work around it. They aren't going to say, I'm going to just pay for that MRI. They can't afford to do that. And that's where we see the outcome differences. So what's our report card, right? We've been doing this now for 10 plus years. We have COVID that hit in the last couple of years, but this system has been off the rails for a while. Well, we've had the big drop in life expectancy, and it dropped again in 2021, okay? And this isn't all because of COVID. This actually has to do with something is not working in our system as it used to be. And we're now number 37. Okay, it used to be everyone came to America for healthcare because we have this fantastic system and we have brilliant medical students and we have technology that no one has. And that's all true. But if an insurance person, a managed care person, a poor person, someone with limited restricted insurance can't access any of those things, what's the point? What's the point? So we have been trying to do this, but it hasn't worked. We've made it a lot worse and not better. And I love the fact that we're below Costa Rica. And I should say we're number 1 in the world for maternal fetal deaths in a developed country. That's just a sin, considering all the access to technology that we have. So that's all the bad stuff, right? It's like, okay, this is not great, Dr. Muto. You just spent this whole time, like half the medical students are like, okay, I'm done. Now I'm going to go work for somebody else. No, stay in your seats. That's not the point. We have a problem. We know where the problem points are. We are doctors. We're going to fix it. So where do we go from here? So the first thing is I'm going to say, read this book. Everyone, every medical student, every doctor should read this book. It's written by a PhD in psychology who's also an economist, worked with a Nobel Prize laureate in Princeton. And her whole research is about how patients think, how doctors think, how we communicate. She's used a lot of times consults with like pharmaceuticals, for example, to see how to communicate with a patient. But she digs very deeply because she does validated studies looking at Princeton graduate students and looking at people who have challenges in healthcare literacy. And guess what? They think the same way when it comes to as a patient. They think about themselves the same way. And anyone in practice for even 3 years, anyone who's seen a patient firsthand knows that patients really know what's wrong with them. Patients actually, they have autonomy over themselves. They don't have to be told all the time. So her whole view is that she takes some sort of 4 things that have occurred in our healthcare system and how we need to morph our current system to fit the new patient-doctor relationship. So patients are first and foremost consumers, right? They have choice. They're paying for it, no question. Every patient is paying for it. Remember, all those poor patients were moved onto the Affordable Care Act. They're paying now, right? They pay a copay, they pay a deductible, they pay for their medications. Back in the 1980s, patients had informed consent. Believe it or not, before 1987, there wasn't an informed consent. I could just operate on you and say, hey, you need an operation. You're scheduled tomorrow. I was like, what am I taking out? You don't need to know. I'll just take care of that for you. That's not how we talk to our patients. Our patients are our partners. We collaborate with them. They come to you with all sorts of information, but it's not bad information. It's the same information you're getting from your textbook. It's the same information. The PDR, the physician desk reference, used to be only to doctors and nurses. Now you can get, anybody can Google any pharmaceutical and understand what the chemical makeup it is, and all their complications, dosage, and indications. And, and it's like, and so that knowledge is now free, right? It's freely available to everyone. So patients are consumers. They are entitled to an informed consent. They go to the internet first, but they still need us because there's a lot of background noise out there. It's very confusing. Patients want to know. It's not do-it-yourself medicine. They have a monitor, they have a Fitbit, they have an Apple Watch that tells them their heart is going fast, but they still need to come to you to find out why. So it is our duty to meet the patients where they are. But you have to understand that this is a collaboration. This is not we know what's best for you. So she makes the argument that the paternalistic approach no longer applies to medicine. And I think she's 100% correct. So when you think about the triangle of trust, trust is based on 3 components: authenticity, empathy, and logic. And the doctor sits in the middle of that with their patient. Ideally, that's all. You have to have, you have to have a degree on the wall, right? You have to be authentic. Your treatment plan has to be logical. That's something patients really, really do require. If you told them, they say, well, you have to have these 3 procedures. And they're like, well, I don't understand why. That's not hurting. Well, you got to have these 3 procedures. They won't buy it. They won't understand it. You have to explain to them, well, this is going to solve this problem and that problem. The patients really do understand logical. And of course, empathy. The most important way to understand a patient is get inside their skin. Understand that how are you going to communicate with them that they have a cancer diagnosis, right? How do you got to read the patient to know how to choose the words, to be able to explain it. That's the core of the patient-doctor relationship. Notice insurance, hospital networks, employers, government, they can't do this. They will never do this. In fact, I'll even say it's not logical. Insurance isn't logical, and it's clearly not empathetic. The more empathetic you are, the worse it is for a business model. And in terms of authenticity, when you have so many things happening about, on the internet and this and that, I mean, what do you believe? right? And there's a real issue of trust. So the doctor has the advantage. We will always have the advantage in this equation. So here we are, post-pandemic, because I think I'm going to say we're post-pandemic when masks are coming up, right? We're here. We have this awful system. We've been working in that system for a while. It doesn't work anymore. That train is off the tracks. So you can sit in the train and wait for the repair crew to come and try to get it back on, or you can think of a new way. The new normal has already happened. Patients, they want convenience, they want access, and they want price transparency. I was on a panel with someone from Press Ganey, and the Press Ganey lady who looks at every hospital in the country that every patient has to fill out a survey before they leave the hospital. Those were the three things that were number one: convenience, access, price transparency. Now you might ask, why isn't it quality? Because quality is what they always throw around. And the reason is quality is assumed. You are all those super smart people who've put in that time. Patients get it, they know. You assume when you get on an airplane that your pilot knows how to fly. You don't choose your pilot, you choose your airline. And that's something fundamentally important, because quality is always bandied about. But in point of fact, in every survey that's validated, quality is always ranked third when it comes to medicine. Patients will trust you. So here we are in a world where knee replacements are outpatient. My 72-year-old patient said, look, Dr. Muto, I got my knee done. I went in at 9 in the morning, I was home at 11. I'm like, what? When did that happen? They do it cheaper. They do it better. These centers are amazing. Babies, you're home in the same day now. You can go home in 24 hours. I had to sign my son out against medical advice because I took him out 3 hours before the 3-day mark, because that was the standard. And now it's like, hey, you got COVID, you go home, and guess what? The outcomes are better. You know, obviously telemedicine and remote technology completely exploded. I mean, it's just remarkable. I always joke here, I have to put a plug in for space medicine, because if you follow the space medicine stuff, it's all this amazing remote technology that is coming into our patients' everyday lives. And it's super cool. Managing arrhythmias, looking at metabolism, all sorts of things. And no question that telemedicine is now part of every one of our practices. We all have an examining room and a virtual examining room. We've now become much more accessible and for a lot less money. And then what about our patients? They're working from home, not just home in the same state, out of state. You could have a person who lives in Austin, Texas, but works in New York City. So what happens to that patient? They're permanently out of network. That means it's not going to work anymore. They're not going to be able to just fly to where their employer has made a deal with a hospital anymore. They're going to need to seek care where they are. So this is a whole new world. It's a new normal. So do we just adjust our system? Do we make some changes in our system, or do we just need to rethink it? So the first thing we do is we have to decide who is the enemy, right? Who are we fighting against, right? And I'm going to say we need to unite. And when I was young, the primary cares and the surgeons were always kind of at odds. Well, the specialists, they want to do a lot of procedures and they make more money. And we say, oh, the primaries, they hold all the cards, they have all the referrals. That doesn't happen anymore. Now we are all on the same page. Every physician who is trained in internal medicine, family practice, neurosurgery, rheumatology, we are all specialists. We are all specialists. We are not providers. We are specialists. And that is really important in this equation, because we are the ones who can sit in that triangle of trust. We are the ones that actually have the capability, the ability, and the duty to take care of those patients. And so we need to unite. And I say, when we divide and conquer, that's how the insurers always win, right? They always win when they say, hey, this one is I'm going to pay this for this patient. Oh, we're doing this deal. It's like, no, I want to do this deal. And the insurance always win. Again, we don't work for insurers. We are physicians and we work for the patients. That is our job. So what if we offered patients convenient access at a transparent price? Seems like that's what they want, right? Can be access and price transparency. Well, that is where the UBERDOC story comes in. So now it's going to be 6 years, March 15th, the Ides of March, when I sat a bunch of doctors, nurses, and managed care experts in a room, and I said, can we fix this? I got this really like silly idea. What if you just could push a button, make an appointment? And what if we did it outside insurance? And what if we didn't make the price high? Like, what if we increase the access and decrease the cost? And they're like, hey, that's really cool. I'd use it. Maybe you're traveling out of town, you need to see a doctor. Before you leave, you want to go. And it's like, because getting an appointment is a hassle. Just pay cash and go see. Use your health savings account. So I went around and asked doctors, would you take a patient for cash? And if they didn't show up, you'd still get money. And they're like, yes. So then I asked my surgeon's lounge. I asked surgeons in other communities. I asked non-surgeons. I went across the country multiple times. I could not get a doctor to say no to me. In fact, doctors came to me. The DPC doctor said, hey, we want to be on your platform. Everyone said, we want to be part of this platform. Every single doctor that I have met has wanted to say, count me in. I want to put a seat in my waiting room right over there, a seat in every waiting room for a direct pay patient. Why not? Why not? It's like we're Ticketmaster. We're having a Broadway show. Here's a seat always available. And we want to see how many seats are available, because you need to have a supermarket aisle for cash, because you can't make everybody go through insurance or Medicare or Medicaid. It's just not right, because patients know what's best for them and they need to have a better option. So the interesting thing about this model is that we started with a few hundred doctors, and now we have a few thousand doctors, like 4,000. And I want every doctor, and I want every medical student to shout it from the mountaintops. I want every one of you, when you finish training, to be an UBERDOC. Of course you'd be an UBERDOC. Why wouldn't you? You would have a seat aside for a patient for a transparent price. And with a federal law of price transparency that's been on the books for 2 years, and the American Hospital Association is saying, we don't want to be price transparent. Every doctor in this country that I've encountered, they want to be price transparent. They want to take care of the patient. So how UBERDOC works is really simple. It can be direct access, in person or telemedicine. Every doctor gets their own webpage. So part of it is, hey, be on the internet, be available to your patient. Doctors are ranked by proximity and availability. So you find the doctor who's nearby and available. Nearby has changed because nearby can be an entire state now, or multiple states in telemedicine. I love telemedicine because the reach is fantastic. It's an immediate payment. There's no waiting for anything. It's very, very popular with these high deductible plans and these medical cost sharing plans. They just want a transparent price. It schedules, bills, collects without a phone call. Many of us don't have a front end to answer those calls because the front end doesn't want to come in and work in a cubicle where there's no ventilation, right? So you have people now that are not answering phones and making those appointments. Where CMS loves us because we're all about access. It's only $50 for a Medicare patient. We're HIPAA protected and we're HSA compatible. Unlike a lot of direct-to-consumer stuff, we're not collecting the money, the doctor is. The patient is paying the doctor, we're just the transactor. That equation leaves the doctor independent and working directly for the patient. And that's probably why it's kind of our secret sauce. And then once the patient's in the door, it's a conversation between you and the patient to decide, do I want to stay with insurance? Do I want to go direct pay? We have, there's many like-minded people that will do imaging, like green imaging. You can get an MRI for $250. There's pharmaceutical companies now out there that will get you drugs at cost. And there's surgery centers out there that are bundling payments and saying, sure, your colonoscopy is going to be this amount. So we are kind of in this new world called this DPO world, this direct pay option. And we don't charge anything to our doctors or our patients when they use the platform only, and unless the doctors need telemedicine or some type of marketing package. So this is our site. It's very, very simple. We made it at the level of a fourth grader for both the patient and the doctor. When a doctor gets a request for an appointment, they just say thumbs up. That's it. An emoji, and the patient is emailed and the processor goes through. And doctors really just put in their availability, just as few as one appointment slot a week, and they appear in perpetuity on the site. So we made it really easy not to disrupt a doctor's schedule, because there are many doctors say, oh, I'm so busy, I've got hundreds of patients. I'm like, you're like a Hamilton ticket, right? Me as a general surgeon, I'm like cats, but you guys, people want you. Dermatology, that's that Bruce Springsteen ticket, right? Those are the tickets that people are going to want and that they're going to want to skip the line for. So now the question is, so we're giving priority access to specialists for a transparent price. And now with in-person and telemedicine. So we are convenient. There's our no-show rates are low because the patient is paying. We're easy to implement because there's no electronics behind us. We're really kind of like, again, dumb technology, nothing simple. It does nothing complicated. I mean, it doesn't have to integrate. We're very flexible and we align really nicely with the new requirements for price transparency. And we are agnostic. We're not limited by network restrictions. And if the patient needs to go on with insurance, they can. We are trying to be a puzzle piece that plugs in and fits in. But we are trying to get every doctor in this country to offer patients a transparent model. If your in-network won't, if your employer won't, if your hospital that you're employed at won't, you can. And I think that's really, really important because it's the first step to get doctors back in front of the patients where we belong. So it's interesting who uses UBERDOC because we obviously have lots of patients that use it who have high deductible, people who don't want to wait, it's convenient, but also the state of Massachusetts finds us very convenient. You know, employers, we're working actually, believe it or not, with our ACO because our inner city clinic can't get specialty appointments. It's almost impossible. So we're going to facilitate those appointments. Imagine priority access for a poor patient with a health voucher. Is that cool or what? Right? This is all just about access and doing it through a direct model. And this is how we're going to change the system. But we have, again, partnerships with, you know, international second opinions, cost sharing plans, and so forth. We have an extensive network and we keep growing. And we are very, very inclusive in our network. So ideal healthcare is convenient and flexible. It always has to be. And we don't say convenient in the sense that it is you know, oh, we want to make it easy. It's like, yeah, we want to make it easy because illness is hard. It's already hard enough to know that you have a cancer diagnosis or that you're having a gallbladder. You're in pain from a gallbladder attack, or that you have, you know, your sugars are off the charts and you feel terrible. The last thing we want to do is put an obstacle in your way to get that care. And now 100% of the time, it's so hard for patients to get what they need. It has to be price transparent. There's no reason why we buy everything. Clearly, why wouldn't you post your price? Accessible is the key. And when people say there's minimal access to care for those that are poor, many of us who work with the inner city patients are like, wait a minute, that's not fair. I'm available. Why are they saying that? Because the word access really means the insurance is limiting access because of the requirements, the data gathering and everything required is putting so many obstacles in the way. It's old fashioned. We don't need this anymore. We don't have a one size fits all model. Medicine is personalized. It's determined by your genetics. We are doing things now that we never did before. I operate in my office, a procedure I used to do in the hospital for 3 hours in an operating room. I don't even operate on carotids anymore. It's unfortunate, but Lipitor killed that business. The minute you put a patient on a statin, that artery changes. So we have such amazing technology that is changing the way we treat patients and where we treat those patients. There should be nothing that stops us from doing this, you know, because just as quickly as our technology improved, we became more efficient in our care. We became less expensive, but everything you read about is more expensive. But what parts of this, what component parts are more expensive? The data gathering, the managed care, the quality review, all these other things that have not positively affected outcomes. So I say that we're not a commodity. We're a service profession. We don't measure our outcomes in dollars. We measure it in lives. And that's the only way you can really practice medicine well. So I like to introduce the concept of the DPO world, direct pay option. It sounds kind of nice, HMO, PPO, I have a DPO. And I think everyone is going to, in your generation coming out of medical school, you're going to need to be part of this equation. You're going to need to have a patient that you're going to be able to navigate through because they're going to come in with health savings accounts and more control of their healthcare dollar. And they're going to participate. So I say universal access with a single payment system, not necessarily single payer. Anyone could pay, but it should at least have a single payment system. There's no collusion. We don't want networks. We don't want to create restrictions. We want to create fewer barriers, not more, because the people who suffer with the barriers are the ones at the lowest end of the spectrum in terms of economics, and we cannot sustain that. That's just inappropriate in our country. And employers, again, with medical cost sharing plans or the self-insured, these are the new age self-insured. They are high-tech companies that are looking for better options. And I think that this DPO option is really going to be able, it's not going to just usher back in sort of a more an awareness of cost, but not just an awareness, something that we can do about it. So I think when you think about healthcare, you got to think differently. You got to think differently. I don't think we can just repair the old system. I think we have to understand that we're not that paternalistic model anymore. We are not in a we know what's best for you model. Managed care has no business in 2022 when patients have informed consent. They do not need to be managed. They do not need to be told. They need to be, a physician is their partner, and we facilitate their care. We don't dictate it. So I say we should think of Medicare as a consumer, just like the rest of us, and the government deserves a transparent price. And in fact, Medicare is more like a health savings account, right? It's like we've been putting into it probably since you were 15 years old. 1.9% of your paycheck has gone into Medicare. So you're putting money aside to take care of your health later. What if, rather than our convoluted system, we reward the patient? Right now, you reward doctors. Doctors and networks get bonuses if you don't utilize. It's like, what? If your patient is, quote, healthy, in other words, if you didn't order tests on that patient, we're bonusing the doctor. Why aren't we just bonusing the patient? It's their health. Reward the patient, not the doctor, for maintaining good health. Imagine a federally funded health savings account that, if you leave your Medicare card in your pocket, you get a reward, a cashback reward or a refund with your tax refund in April. And then you're incentivized to once again pay that small step out of pocket. Go to your primary care for that annual physical and pay them $250. Why not? Because you could be getting that. And then when you go to the hospital and you need a cardiac cath, it should be paid for 100%. So getting patients to be more cognizant, decreasing utilization, and our dependence on insurance alone. I'd say the insurance companies are like big pharma and big tobacco and tech, right? They created a product that we're addicted to. I think we need to change that, and I think we can. And again, carving out that primary care piece, pay your doctor out of pocket, leave 100% coverage for the big stuff when you go to the hospital, when you need an operation, moving patients away from, from this kind of black hole of feeding this marketplace, feeding putting your money somewhere where it's never going to come back and help you keep you healthy. So I always say inside every doctor, there's an UBERDOC. I do believe, because it was built by doctors. We are all physicians. We are all together, and together we do prosper, because we need to work together. And it is something that we do from the ground up, because we can meet the patients where they are, and no one else can. And with the technology that we have between telemedicine, remote monitoring, surgery centers, this super AI, this wonderful AI that's compressing how we treat all of our patients in such a cool way, we don't necessarily need all this nonsense around us anymore. We can do this much faster and better. So in conclusion, we're going to take all you clowns over the mountain. I'm going to take you with me over the mountain. But it really is about the fact that we can do this, and we do this together. And I'd like to just thank you for the opportunity, and I hope there are questions out there.
Thank you so much. Somebody texted me and said, I can imagine the two of you on a panel together, because you two are the biggest cheerleaders for this in the whole world. That must have been so much energy. I just read that. Yeah, there was a lot going on there. I have questions from all over your presentation. And I still see them coming in. I want to start with something from early on that you mentioned, and you spoke about the data control and the privacy issues. And I think that is something that, we haven't spoken a lot about in this series here, and I think is something that we need to talk a lot about.
We need to talk about it.
We do. Just briefly, what do you think maybe a first or second step that needs to be taken in terms of what needs to be done? Is it state level? Is it federally? I mean,
it's
what can be done?
Actually, very simple. It can be federal level. You anonymize the data. Other countries just anonymize it. And if you anonymize it, it has no value. Right now, we are first name, last name, social, address. I have seen software programs that integrate into revenue cycle software in hospitals that include your credit score. So that means when that e-prescription is made, CVS doesn't just see who you are, what your insurance is, who your employer is, what your plan is, but what your credit score is, so what you're likely to pay. So it's pretty awful. You anonymize the data, you're nothing. Nobody cares, right? You can still gather the same information. How many diabetics? How many age? What's the average age? What's the demographic? What's the gender? How many people that are 65 are taking Lipitor, right? You can get all that information. In fact, when you look at some of these really intriguing, there's some startups that they're using AI algorithms to predict, drug effects. They get shared data. They get it from like big national organizations, and it's immediately anonymized. And then they give them the data, and it's just age and disease and drug that they're on. That's it. So anonymizing data is absolutely possible. It also removes the silos, because you can't share data, right, between electronic records. That ship has sailed and no one wants to even try. So anonymizing data would be the first step. The second thing is patients should have their data. Patients should control, and that is easy. We all carry our own, profiles on our phones, right? It's like so easy to have your own portable medical record with a big barcode that you swipe when you go into the doctor, and then it disappears afterwards. And you just keep the relevant information the doctor needs for that patient. And that's just the story of the patient, right? So we have created this data requirement mostly for managed care, and that's one of the reasons with our ACO, we said, okay, let's manage your appointments, right? Our accountable care organization, drowning, they can't get specialists because a lot of them are Medicaid patients and they're at the end of the line. It's like, okay, let's put them at the front of the line. Let's just use UBERDOC. We'll pay the doctor. They won't have to make a claim, right? They're seeing these patients anyways, just put them at the front of the line because they know it's going to be cash. And you know what the response was? How are we going to collect data from the claims data from the E&M code of the first visit? It's like, okay, collect it from the second visit? I mean, what can I tell you? It's just nonsense. And what do you need that data for? That data is somehow coming back at that patient and taking something away from them, right? The whole purpose of the data is to, quote, save money and decrease risk. But what in reality, in practice, that data is used against the patient. So it says that we're going to deny that medication. We're not going to cover that wound service. We're not going to cover that MRI. And so again, the data is an easy fix. You anonymize it. It's been done around the world. That's why Israel gives us all the data in 2 seconds every time when something's happening over there.
Absolutely.
Right.
Absolutely. And I think we saw that a lot during COVID. We saw all this ability to where we were getting reports, and, it was all coming from people who have done this and from countries rather that have done this.
So anonymizing it is a top-down thing. The value would crash, right? There's a lot of companies that sell data.
Absolutely.
But medical data is inaccurate, right? The way all of us interact with electronic records isn't accurate. We tell the story, and I tell my residents this all the time. Well, I have surgical residents and family practice residents. I tell them all the time, dictate the story of your patient or write it. You have to have a paragraph of the story of your patient. Your patient is telling a story. That's the most important piece. And then all this other kind of like structured data can come in. But if you don't tell that story, it just becomes all structured. You won't know who you're taking care of. Literally, you won't know who you're taking care of. Because it's the same. And there's so much that we do macro, like it's the same. But the first paragraph is always the story of the patient.
Right.
And
I wonder if that is what our other students are hearing as well when it comes to taking the history of their patients. If they're hearing
story, and unfortunately, their priority in the hospitals is the invoice, right? Because if you don't, so this is an interesting thing. Remember that picture with all the yellow arrows? One of the things they tell you all the time when you go in a hospital is, oh, Dr. Muto, could you just add this code in, add this diagnosis code? Don't say K with the arrow up, say hyperkalemia. And now you click a box, add diagnoses in, please. And I'm like, why are we adding diagnoses? These are like Medicare or Medicaid patients. They're on a DRG, which means that they're going to get a flat rate for that no matter what. But as we learned in Texas, the charge escalates.
Yep.
The payment remains the same, but the pretend negotiation that occurs is 12% on the spread. So it encourages people to overcode, even though you're not getting paid for that, but someone is. But the hospital is, right? You're not getting more money from the insurance company. You're just getting more money off the spread. So it's not good practice. It's just not good practice. And because so much of this is now harming patients, it's a boomerang effect. The more we enable, the harder it gets for our patients.
Yeah. How to change that system is an entirely different webinar altogether.
Right.
I want to get into some of the questions. I try to keep these right at about an hour. I want to get into some of the questions about UBERDOC itself. First of all, there's a question, are mental health providers, both of any kind, healthcare providers, physicians that treat mental health, are they included in UBERDOC?
Oh gosh, yes. Oh no, psychiatry is big. Oh no. So we have psychiatry, we have PhDs in psychology. But in our state program, we actually also take licensed professionals. Typically, the UBERDOC platform is physicians, again, PhDs in psychology, podiatrists that are foot and ankle certified, and optometrists, but everyone else is DO or MD, to be on the site. And I always say, we're the site for the over 35-year-olds. No one really no one on our site's under 35, right? I'm just gonna put it out there. But behavioral health services, huge demand. There are a lot of services out there, and they're hard to wade through. So we have a tremendous, that's one of our biggest demands is psychiatry and psychology. And we are very proud of that we're able to have people in different parts of the country that are able to access care. I think that is a challenge everywhere right now. I will say also that behavioral health in general, how it's treated even in our health center, for example, a lot of our family practice residents became de facto behavioral health specialists, and there's a lot of prescribing going on. I'm just saying there's a lot of prescribing. I had a lady yesterday, 75 years old, with 25 little bottles in a plastic bag. And about 6 of them were either anxiolytic, the trazodone, the Effexor, these drugs that a 75-year-old, and I said to her daughter, she said, well, her husband died a year ago. She's depressed. It's like, oh my God, is she really taking all these medications? Who is she talking to? And she has a behavioral health specialist and a primary care, but I wonder if they're really talking.
If they're talking to each other, yeah.
And so the tendency to prescribe or re-prescribe or renew the prescription, because I thought this is crazy. How could you possibly take 25 pills? And all of them are at best have a 50-60% efficacy. So I have to say that we do have a behavioral health crisis, but I'm not so sure it's going to get solved with prescribers.
So do the physicians set their own prices? How does it work with that initial price structure?
Yes, the initial price, the physicians can set the price. We have a default price of $250, which sits in the Medicare kind of a little bit above Medicare. We're like a 1.25, 1.5 Medicare model, reference point price for that visit. But they can set their price anywhere from $150 up to $500. They can't go beyond those. $150 is the lowest we'll go, because we don't want to look like all those other things out there that are kind of like, these other other companies that are kind of, hey, we'll give you, we'll give you your anxiety pill and we'll take care of your IUD. I mean, there's some companies out there doing some strange stuff. So we wanted to brand ourselves and separate ourselves that we're real doctors. I say really, we're UBERDOCs, right? We're specialists. We're trained at what we do. We're like the Navy SEALs. You're getting that, and that's the value in the consultation, because you're paying cash for it.
So after and I'm trying to understand a question that came in. The question itself and how it reads is, does the system allow holistic functional medicine docs to spend more time?
Yes, we have regeneratives. Yes. Oh my gosh. So the fun part about UBERDOC is I get to meet all these cool people. People come to me all the time and say, I want to be on your platform. I'm like, okay, what do you do? And we have regenerative medicine. We have a lot of really interesting. We don't do acupuncture and chiropractor. We don't do that yet, just because our brand of UBERDOC was really focusing on the medical, like that specialist, right, that you can't get into. And there are other platforms out there for that. So we kind of wanted to distinguish ourselves a bit. But there's a whole world, and my passion is women's health, to build that women's health vertical with all those components in, maybe, on the cancer side. It's just, things are so exciting right now when it comes to medicine. We have this doctor in Nebraska who's a neuropathy expert, and he has this new procedure for neuropathy, and there's only 2 or 3 people doing it, and he's getting these great results. And I'm like, oh my gosh, that's so exciting. So there's some doctors out there that are really doing unique things on the cutting edge, that patients that really seeking that care. So yes, the holistic, my ultrasound tech in the office is a doctor of acupuncture. Everyone's Reiki trained in my office. So from very beginning, I've always had a bent toward holistic. As far as putting them on the platform right now with our price point and everything else in our brand, we're trying to keep it simple, as it's the specialist, the doctor, and go from there.
Is, now that you've grown and now that you're 6 years in, do physicians come to you? Do you go to physicians? If there was a doctor that was interested in being on your platform, or a person like me was interested in their doctor getting on your platform, how would that work?
You just tell them about UBERDOC. So it's still, we are, I used to say we're the best kept secret, right? It's like a word of mouth. So we actually reach out to doctors directly through like email campaigns and so forth. And then we've gone to, back in the day when there were trade shows, I used to go to my surgeons, American College of Surgeons, and tell people. And so it becomes like that. And we do that. We go directly to doctors. And we've done some digital marketing and things like that. Ideally, I want the patients to drive it. I want them to say, hey, I want to make an appointment with you. I told my gynecologist, I'm like, listen, I have to put aside like 3 hours to make an appointment with you, because they call you back. I was in the OR. I got the page. It's like, oh my God, I can't, I don't want to go through that. I just want to push a button, make an appointment. And I don't even care. I don't want to get a referral. I don't want to do that. And I just want to pay you out of my health sector. I just don't want to go down that path. And I just, there's no reason. It's inconvenient. It's annoying. I have a health savings account. I just want to use UBERDOC. So sometimes it's getting the patients to tell the doctors, hey, I have this new kind of, I don't want to say insurance. I have this new kind of healthcare. So we have a lot of partnerships growing now with the medical cost sharing groups, and they have always traditionally partnered with DPC doctors, but they needed specialists. So we're kind of coming on board with that, with the doctors, and that's pretty exciting. And so with that, as we start to talk to more and more employers and more covered lives, there'll be more demand on that part. So I just think it's already working with a hushed, with a very quiet kind of like behind the scenes approach. I don't have any doubt, considering the traction that we've gotten already, that it will be something, as you say, the patients will drive it.
I have 2 more questions, and then the question that I always ask. The first question is for physicians that are interested in, perhaps, and this is a shame for me that I haven't looked at the platform, which needs to change.
That's okay.
I know.
I haven't either. No, I have to say, I birthed it. I was part of every aspect. And I just want to say, for anybody out there who wants to build a technology, Agile is a great fun to do. Building a platform is fantastic, especially as a doctor, because you're problem solving every way. But anyways, but I birthed it, and still I haven't looked at it all the time.
Is especially, a specialist that might have their own practice and is trying to find a particular type of person that, can they search? Could they narrowly focus their searches so they can attract patients who are coming? How does that work?
So we have a marketing plan so because we're good at marketing, right? And so my team, of course, markets my vein center, and veins are very specific. And so they practice on me, right? So yes, you can absolutely, so we have a marketing team that will work with doctors individually. We market UBERDOC, right? We market and specialty verticals, with GI or oncology or whatever. We have that opportunity to do all those specialties, but we can also work with individual doctors because each doctor has their own landing page. And that landing page can connect with their website. And then we like each other on Facebook and it amplifies. Like there's little things you can do that don't cost a lot that make it good for the doctor's website and good for UBERDOC. And we are able to elevate doctors. And many doctors don't have websites, or they are forced to pay a lot of money to have a website. And that was sort of, I didn't like that, I was paying a bunch of money to people to keep me like on the top 10 of Google until I saw this male radiologist on my site. I'm like, excuse me, that's not me. So yes, we can work with individual doctors who want to market their practices. And my marketing team loves those doctors because they talk marketing. Which I personally find very confusing marketing. But I said, can't we just get a billboard or a TV commercial? They're like, see, I don't know what's going on, right? I'm like, I want a TV commercial. That's what I'm thinking. But yes, we do work with doctors individually. Okay. Sort of like my moonshot with UBERDOC is that those specialty verticals for the doctors, like where we create an ecosystem of oncologists or like pulmonologists. Like we have an interventional pulmonologist who's trying to change like lung cancer, like stop lung cancer in women. She wants to stop lung cancer in women. And it's like, wow. And she has this whole cool thing where you family history, genetic testing, telemedicine visit, low dose CT consultation, like wow, right? That's the kind of thing that it's our platform just lends itself to, like in introducing those kinds of models, which wouldn't just work in Pennsylvania. It would work for a pulmonologist in like Ohio.
Right.
Who sees that and says, wow, that is so great. And so we create like ecosystems. And I should say, like our rheumatology, we Dr. Granita, like amazing, right? Like that is like, those are the kind of people we have on our platform with this immense skill set and able to not just share it, but build the vertical. I always say 8 million people with gout and 4,000 rheumatologists.
And I almost called her the other day. So I think what I find most interesting, I find a lot of what UBERDOCS, I find you particularly in your advocacy for your profession to be so refreshing and so wonderful, because I tell medical students all the time that advocacy can look a lot of different ways. There are so many different ways as physicians that they can be advocates for their profession. What you did was you created a way to make change in healthcare. And not only are you an outspoken advocate, but you created something in order to change it. And that is fascinating to me. And it's inspiring to me. I think what else is we're saying to the students, and I say this often to them, I don't have any preconceived notions. I'm not naive enough to think that every single medical student is suddenly going to go in and open up a direct pay practice right away out of medical school, having $200,000 in debt. I'm not that naive. That being said, you're giving them a way to participate in the direct pay, in the DPO, the direct pay option, and change healthcare. They're being advocates by allowing doctors to do this. they are making that change. They're participating in this and allowing patients to have more of a direct hand in their care. That's awesome. I mean, it's fantastic.
Well, that's how change happens, though, right?
Yes.
We don't take down. We create from the bottom up, right? Again, it's that seat in the waiting room. Just give me a seat, right? Just give me a seat, because today it's one seat, maybe tomorrow it'll be four.
Right.
We don't know. We're not emptying your waiting room of your Medicaid patient or your Medicare patient or your Blue Cross patient, right? That's not it. And I think it's hard for some doctors who are faced with the challenge, especially primary cares, with the overwhelming cost of running a practice and then having to give up their panels to go direct pay. And they lose a lot of their patients who don't want to do that. And the patients aren't prepared to do that. So I say to them, well, dip your toe into the concierge world, be a hybrid. Like, the electric car, you got to drive a distance, you put the oil in the car, right? I mean, there's no reason not to. And I think a lot of times our system and our education and our kind of culture that we've been kind of fed all this time is that there are no choices, right? This is what you have to do. You have to do this. You have to document this way. You have to do this. Again, this paternalistic, monolithic, misogynistic model of medicine that we've all trained in, that's essentially wrong, right? We have to rethink this. And I like to think when more women enter medicine, and that maybe things change, but really everything else in life we've changed, right? Everything else we talk about as a collaborative. Why isn't medicine exactly the same place? And you begin to say, no, it's wrong now to tell your patient, right, they have to do this, or you have to take this medication because insurance said so, because this is the one I want to prescribe, but I'm going to give you this one instead. I'm going to tell you a story that's been very upsetting to me, because it's a patient of mine I've had for years, and during the pandemic, she got her vaccine and she got sort of inflammatory response, and long and short of it, she developed a pretty awful thing in her breast, and I've been following her for years, and I couldn't get her. We had tried to biopsy her. She needed an MRI. I couldn't get her MRI. I had to fight every layer. She was an ACA product, managed care. I was fighting. They had 3 layers I had to go through of people to ask permission for this. And I'm like, I'm a specialist. She needs this. And I had no other avenue to pull the trigger and just go, right? I'm just going to send it. We'll worry about the bill later. They wouldn't even book her without the approval. And so finally that all happened. Finally, she got her diagnosis. She's metastatic. We knew that. The day before her chemotherapy, she calls me in hysterics. It was canceled. Insurance hadn't approved it yet. I'm like, are you kidding me? They're going to approve it. Of course they're going to approve it, because they could, that story. And I was speechless. I'm like, I felt so powerless. And that's when I know we've failed. We have failed to let that ever happen. So I immediately texted my oncologist. I'm like, what's going on? And he's part of a huge, well-known brand name cancer center, right? It's the monopoly in the New England area now. And he said, Paula, I know what to tell you, but this happens all the time. I said, no, if it happens all the time, then we stop right now. Yeah.
And I think you've just hit it on the head. If something's happening all the time, it's time to make a change. And,
right.
I think that's something that we're seeing you figure out an innovative way to make that change and to advocate. And that's, I find that so powerful in what you're doing. One of the most interesting things I have found about working with medical students and with physicians is there's often a fear of how to advocate, because you're working for, or you will be working for, that big hospital or those big insurance companies, and what that means to your profession and your career. And it's very heartening every time I hear of an advocate like yourself and finding ways to advocate for your profession.
Because you work for the patient. So my father was a great surgeon, and he used to hear me squawk all the time. Dad, at the hospital, they're doing this. Dad, and he's like, been there, done that. The way history, it's like, hey, the more things change, the more they stay the same. He used to always say that. But he said, what do you care? just take good care of the patient. Trust me, just take good care of the patient. You'll be fine. The patient will be fine. You'll be economically fine. The hospital will be fine. Everyone will be fine, right? It sounds kind of simple, but it's like true. Just take good care of the patient. Wow. And good care isn't difficult. That's what I'm saying. We train forever. We kind of know. We see a million legs, you see a million irises, you see a million throats, you kind of after a while figure it out, right? I mean, that's what we do. You take care of enough hypertension, you figure it out. So why are we questioning that? Like at all? And why are we questioning?
You have to be able to treat your patients, and your patients need to be able to see you, and that's what you're doing. So my students are in that are external have limited time. So I need to cut our time short today. I could talk to you forever, and I know that some people are going to have some additional questions. I will be sharing contact information for Dr. Muto, as well as how to get to view the UBERDOCS platform. And to become an UBERDOC, because I see
everybody
that there are
join UBERDOC.
I see that
we want everybody on UBERDOC, and I see some things coming through about like labs, things. I can tell you, everyone comes to me every day with, hey, we can do prescription drugs. Hey, we can do labs. Hey, I mean, every day, everybody wants the DPO, right? There's enough innovation out there.
Dr. Silverman, I will get in touch with you, and I will share Dr. Muto's contact information because I see some of your questions that are coming in, and those are great. Those are great questions for her. We will have this up on our YouTube channel. If you haven't been to our YouTube channel, please look up Benjamin Rush Institute, and you will find all of our virtual event series videos, as well as some of our wonderful events that some of our chapters have been doing recently. Please sign up for our newsletter on benjaminrushinstitute.org to be notified for our newest events coming usually every month. Dr. Muto, thank you so much. Thank you for everything that you do. And thanks for being my friend. I appreciate you. And thank you for supporting everything that we do at BRI. To everyone else, thank you so much for joining us, and have a great afternoon.
Take care. Bye-bye.